for this last session of the day, in this hall at least. And I'll welcome on stage our chairperson, Dr. Ashmin. Dr. Jayanta is in another session, so he'll be joining us shortly. Dr. Harshvardhan, yes, please. Dr. Nibha, I don't think I could see, and of course, I'm Dr. Rohit Saxena, your moderator. So we'll okay. So we'll have Dr. Harshvardhan, who will be talking on optic nerve fenestration, our experience and advances. An extremely
first of all, thank you, Dr. Ashmin, for adjusting me because to put my talk earlier, because I have a flight which is preponed actually. And at the outset, I would and at the outset, I would like to thank the AIOS for giving me this opportunity. So this is our experience about optic nerve fenestration surgery that we do in Navi Mumbai. We have done almost 282 cases now, and it's about idiopathic intracranial hypertension, but we also do it for dural sinus thrombosis, and we have got excellent results in terms of visual acuity, not only saving but improvement, and also symptomatic improvement in terms of the headache part, which is very common in such cases. So we'll just quickly go through the presentation. So we all know what is IIH. It is increased intracranial pressure with the other symptoms of headache and obscuration of vision, intermittent, sometimes double vision as well. And we use fundus photography, perimetry, field tests, OCT of the optic nerve, and MRI for diagnosis. Usually people are in their 30s, and the male-female ratio is usually 1:5.5 according to a study. And another study says about 24% people develop blindness after such a condition. So it's very significant in our community. Underdiagnosed, mostly goes to the neurologist, and they fail to send it to the ophthalmologist or any neurosurgeon, and ultimately leading to blindness. And various risk factors, as we all know: male gender, hypertension, anemia, black race, etc. And indications for surgery usually at our place is worsening of visual fields, presence of visual acuity loss, which is quite significant, intractable headaches, anticipated hypotension if the patient is going to undergo some kind of renal dialysis or something, which can lead to sudden ischemic optic neuropathy. So in anticipation, we can do this procedure, and unable to participate in follow-ups. Certain patients cannot do that because of their condition. And various complications encountered could be diplopia, pupillary dysfunction, visual loss, which is usually transient but sometimes can be permanent because of damage to the nerve during the surgery. This was a pilot study we had done before, and about 28 patients, and we had 10 females, 4 males. Average age was around 41, and follow-up period was about 12 months. And elevated pressures that we took were above 220 millimeters of mercury in non-obese adults and 250 in obese adults. Neuroimaging studies were done. Papilledema was diagnosed. Neurologic examination was done by the neurologist, and there was no other significant neurological anomaly found except IIH. And decision of surgery was taken when there was progression or there was sudden, the acuteness was severe, and the severity of loss, despite maximally tolerated medical therapy, was considered to be the indication. We follow the medial orbitotomy approach with or without endoscope. This is the surgery in short, where we expose the medial rectus muscle, we detach it, then we hook the superior and inferior rectus muscles as well, so that we can get a grip on the eyeball and take it to the lateral side, so as to expose the blood vessels, plexuses, and the nerves, and basically the optic nerve. And once that is exposed, we take fenestrations, allow the fluid to flow, slightly enlarge the openings to create a valvular effect, and then close. So we have found excellent results in terms of visual acuity improvement, as well as saving of. So you can see the fluid flowing out very nicely. This is the CSF through the optic nerve sheath. And these are the results. This is pre-operative. You can see the head of the nerve, and post-operative, the mountain is gone. It's formed a valley there. So the average time we found was 110 minutes, but with endoscope it was slightly reduced to 102 minutes. Endoscopic surgeries usually reduce the inflammation and therefore the secondary fibrosis. Average time in reduction of optic disc swelling was found to be around 7 days, and the visual acuity improved in 26 out of the 28 cases. The fundus picture and perimetry improved in 27 and 26 cases out of the 28 cases, and OCT showed a decrease of about 216 microns, plus minus 93. Complications were lid swelling, diplopia, transient visual obscuration, pupillary dysfunction. Video recording was done of all the procedures for video auditing these cases, and it has been found that perimetry is optic nerve head tomographic abnormalities can be well diagnosed by perimetry and OCT, and they are both equally important. However, OCT plays a even better role nowadays, and there was a significant correlation between visual field sensitivity loss and papilledema according to this study. And OCT is a must because the trends observed over the follow-up period support the use of both techniques, OCT and perimetry, and specifically OCT. But sometimes OCT has a problem whether we don't know whether we are actually losing nerve fibers or the papilledema is reducing, because sometimes patient is going into optic atrophy. So we initially had described an index which was called as discriminant function index, pre-op disc elevation upon post-op disc elevation. And these are the photographs of pre-op and then post-op day 3, day 10, 1 month in one of our cases. Perimetry, you can see generalized visual field loss and sensitivity loss, which improves after the procedure, and the optic nerve head also shows flattening. So recommendations for treatment are limited by the absence of randomized controlled trials. This is one of the studies by another author, which they also followed similar approach, and it compared with our study. And our results had longer follow-up of 12 months, more percentage of good results due to following of an index, and OCT was used in all cases. But now we are further refined it. We are now using the Wolfram language algorithm. It's a unique engine which uses algorithms to analyze, answer questions, generate reports, programming to further improve prediction of success. So we can now predict whether this patient is going to improve in terms of visual acuity. And we have fed a lot of data in this. This is available online, Wolfram Mathematica. And once you enter the data, you get, these are the various parameters that we enter from various machines like dynamic retina analysis, fractal dimensional, visual vessel discontinuity index, which we see on HRT, disc margin obscuration, Brooks membrane, submacular fluid, OCT, perimetry, fundus, MRI, many things, visual acuity pre-op and post-op. So this has really improved the results in terms of prediction. And this was another paper that we presented last year. We got a prize for that. And discussions. So the strength of our study was basically we used most of the parameters that are available, including video audit, objective and subjective parameters, and were assessed, use of endoscope, and a large follow-up. And it was a multi-centric study across 4 hospitals. Now we have crossed around 282 surgeries of this particular procedure. And conclusion. So all 3 parameters, including perimetry, fundus, OCT, are important. The Wolfram language algorithm now helps in prediction. OCT is very important. Endoscope helps in improving the results, and applying the index and algorithm saves most of the gives good predicts the prognosis. And in short, ONSF or optic nerve fenestration is a very quite safe and rapid procedure. You can discharge the patient on the same day. You don't have the ventrocularis VP shunt required for such cases. We save complications of that procedure and the cost, and it gives good long-term results, including symptomatic improvement. The headache also goes away in most of our cases. So these are the references. Thank you very much.
Thank you, Dr. Hirsch. Couple of points. One is we wait for your your algorithm to get published. I don't think you published this.
No, we are not published.
So I think that would be an interesting addition once it goes through peer review. And the second point is about, do you have a number or percentage as to how many of these cases had a premature closure or they required a second surgery?
So, looking at anatomical, we really don't know what's going on inside, but technically, we had 2 patients who lost their eyes even after the procedure in that study, particular study. But in the long run, of all the cases we have done, I would say maybe 1% patients do have problems of recurrence, and we then refer them to the neurosurgeon for a VP shunt. We don't repeat the procedure usually.
How many times have you had to go in for the other eye?
No, we do both the eyes at the same time.
Okay.
It's usually bilateral. It's bilateral papilledema in IH and dural sinus thrombosis cases.
Yeah, we usually do one eye and we get good effect in both the eyes.
Okay.
So that's why I was
Yeah,
asking.
that's a good
Sure.
point. Yeah.
Is it done by neuro-ophthalmologist or is it done by orbit
Yeah.
As anybody can do it.
Anybody
He's
can.
a cornea expert. from
Yeah,
what I saw
I
at
do
the
it with
beginning
my
of this.
oculoplasty surgeon, Dr. Morekar.
But yeah, because most of the patients present to a
Yeah.
neuro-ophthalmologist, it's like bulk, but because they are also strabismologists, so it's easy.
the risks are more with the VP shunt or are the complications more with this?
So essentially, I don't think there are any major issues as far as the risks or side effects are concerned. It's more like at our center we plan that if the patient has headache or has very, very high CSF pressure, and then we ask for a VP shunt rather than go for an ONSF, because we haven't seen very significant reduction in the CSF pressure, because the shunt, what we do is a very small 1x1 or a little more. So it reduces the pressure around the optic nerve, but does not probably cause significant and not improve headache, and at least in our experience, to a great extent. So if headache is a primary problem, tinnitus and that or high CSF, then we request for a VP shunt. If it is the visual deterioration as the primary problem, we go for a optic nerve sheath fenestration.
Has been the longevity of the procedure. A lot of people have, like say 6 months, 5 months, they start using mitomycin.
Yeah, although I didn't like the idea of using MMC right next to the optic nerve, so I haven't, except once or twice I tried. The only advantage of using MMC is that those vessels kind of get blanched, which are on the optic nerve sheath, which are very distended, so sometimes it causes a bleed when you make the sheath opening. But other than that, I feel a little hesitant to use an.
Any risk of optic nerve damage during the procedure?
Yes, definitely.
It is there. That's why I was saying we prefer to operate on the worse eye. That's why we do one eye, we operate on the worse eye. So the risks are less, the likelihood is there, but if it is a distended optic nerve, and we stop acetazolamide or any medication the patient may be on a day or two prior to doing this process, so we get a good distended sheath that makes it easier to go in with less risks.
And we do kind of multiple fenestrations, so the chances of failure become little less.
And of course, with the help of endoscope now is little easier. So you can visualize. Rather, if it is failed, then only that neurosurgeon can go for a shunt. So ideally, the ophthalmologist, those are basically doing spoon and oculoplasty, is better. Or otherwise, that ENT surgeon can open it up, and it will be little easier for them direct visualization and that.
So you want to go next?
Yes.
So we'll just request our local host, Dr. Anita, to wait for a bit. We have a lot of people who are keen to go. So, including our very dear chairperson. So we'll have next by Dr. Jayanta Kumar Das, who will be talking on the role of ophthalmologist in the management of keratocavernous fistula.
Good afternoon, everyone. So the role of ophthalmologist in the management is a very, very important one because most of the time the ophthalmologist may be the first to encounter in CCF, not the neurologist or neurosurgeon. As we know that there is some theoretical part, is the abnormal communication between the cavernous and carotid arterial system. It may be a pre-existing some anatomical abnormalities or following trauma. Most of the time hypertension and other systemic diseases are one of the factors, and it was first reported in 1930. If it is a high flow, it is very, very easy to detect so there may be swelling, all triad of the three are there. But if it is a low or indirect, sometimes it may be very, very difficult, then the role of ophthalmology are very, very high. So this is one of my patients. She was actually in ICU for a pregnancy-induced hypertension, and later on she developed. She told after that, so the immunosufficient sudden, and ophthalmological opinion was taken. Someone detect as BRVO. Yes, of course BRVO, CRVO is okay, no issue. But what is the cause? Hypertension also may, but this is not only only the retinal vein. Then when we look in that, there is a congestion in the circumciliary congestion. Apart from the retinal findings, there is a blood in Slem's canal. So next investigation, MRA, it was detected as a CCF. Some are in post-trauma, it will be very easy. Of course, I already mentioned. So then there is a engorged vessels even in the lid, so we can detect it as a thing. But our role is not only to detect. From our hypertension point of view, we can look all cardiological evaluation, then care for corneal. Sometimes there is a proptosis. It's one of the triad, one of the finding in case of a direct, there is a proptosis. So our treatment starts from the corneal protection. So we can go for, and the IOP. Always there is a range of IOP. So we can take care for IOP, etc. So those are one of my patients. It is a long-standing hypertension. There is there may be pre-existing some anomalies on the some vessels. So there is ultimately there is a CCF. It was also misdiagnosed as a hypertensive retinopathy. Yes, there is maybe hypertensive, but may associated there is a CCF. So those are the important points. So we can look all. So coiling is one of the options done. As I already mentioned, the CCF, there is a triad. It's as per the book description, pulsating of the ophthalmos, ocular chemosis, and orbital bruits. But it may not be in all the cases. Only one or two may be present, especially in indirect variety. So we can look all. There is a cranial nerve paresis. There may be IOP rays. There may be on gonioscopy. There may be a blood on Slem's canal. Those we can do. Another important is that what is not in the book even all, the corkscrew appearance of the vessel. Once there is a corkscrew appearance in the vessel, and in the ultrasound, there is a hockey stick sign. Hockey stick sign is and due to the enlarged superior ophthalmic vein. Once in all CCF, there should be enlarged superior ophthalmic vein. So due to the back pressure. So this is another diagnosis in our hand from ophthalmological point of view. We can do a ultrasound, we can do a gonioscopy, and then we can detect most of the time. Then our investigation will come. The investigation of choice is generally MRA. But it depends on you, if your neurosurgeon or interventional radiologist wants to perform in a same setting. If you almost you can confirm it, so it is a CCF, then in a one shot it can be treated. As I am now working with it in Apollo Hospital, it will be easier because interventional radiologist and the neurosurgeon is must. Then we can treat in the same sitting. Otherwise, when I was in a 20 years in a one eye setup, so then it was difficult. So that investigation is first MRA or MRI, whatever. But now I just detect in each and every case, and then in one shot finish it. This is one of the patient that I want to mention. 22 to 23-year-old boy is a cousin brother of one neurosurgeon and plastic surgeon. They operate by plating. Due to the road traffic accident, he was in unconscious mode for 2 to 3 hours. Then he was in ICU. Then there was some injury. Next day, he was operated by plating. Okay, fine. When his brother sent me to that examination of the eye, he told there is a dull ache only, eye ache. When I examined, the corkscrew appearance was there, but their pressure was high, 28. And then I did a gonioscopy. Of course, there is a blood in Slem's canal, and there is a faint bruit was present. As there is a history of artery, RTA, so I thought it may be CCCF, but the question was the diagnosis. Of course, our clinical diagnosis was CCF, but how we can confirm it? As per the book recommendation, we should go for a MRA. But as there is a plate is there that radiologists refuse. They will not go for any cost. Then I told, so you can go for at least CT angio. The CT angio is the next option. The reason of the CT angio is that we can detect the loose screw. If it is in orbital, MRI is not contraindicated, but if there is a loose screw or something, then we have to go for a MR. So MRI or MRA. So in a same shot, it was confirmed there is a no loose screw, etc. Plate was in situ. So we performed the surgery immediately after the 2 hours after the GE recovery. You can see that there is a bright white eye in both the eyes. So it was coiling was done. Though this is just like for you. Our interventional radiologist performed this is true eye vein, and that's coil. It can be it is by visualization they can pack it nicely. Those are the coils. It may require 2 coils, 1 coil, whatever. We can just pack it. This is a simple procedure for them. But for our use, there's a paramount necessities are thorough history, detailed examination. There should not be any shortcut in our examination. Of course, for investigation, choice is the MR angiography. If there is some other causes for pacemaker, etc., then we can go for CT angio also. So my take-home message is ophthalmologists may be the first to encounter the patient in clinical manifestation of CCF. At the present paper, it will help to understand the clinical features, current diagnostic approach, and possible modes of treatment and outcomes. Thank you.
Thank you, Dr. Jayanta. Any questions from the house in the current presentation? Yeah.
Is there any papilledema in CCF?
Sometimes, but most of the time there is a other hallmark finds her because there is a back pressure on the vessels, not on the disc. In intracranial, because it is cavernous sinus situated in the frontal part of the bone. So any frontal bone, not all the frontal, because that it is basically pressure on the vessels. So superior ophthalmic vein, or there may be a BRVO, there may be other features of the vascular system, not exactly on the nerve. Because here nerve is little protected, but there may be a papilledema, but little less in comparison to the other.
So usually unilateral, usually CCFs are unilateral, and essentially there is no raised ICT under at any time. So it's just that localized raised venous pressure, and the superior ophthalmic vein, being the largest draining vein, gets the brunt of the back pressure because of the CCFs. And usually these are small flow CCFs, so the back pressure is not all that much, and so the ophthalmic vein does not show so much back pressure. But
You don't need to treat every case.
so again, that's little difficult depending upon sometimes a very small CCF one does, they may just follow up. But now, of course, because interventions have become very, very simple, as he's shown, the coiling is so simple now that one would err on the side of going for it, because they would tend to have over time complications of, so glaucoma, you will have complications that will develop.
High flow you end up treating.
High flow,
Low
yes,
flow, if you are able to manage or follow up for glaucoma, then maybe you can wait. Depends upon the.
Ma'am, what happened earlier, it was observation. Because that time, our team was not so tuned. Now the team is so tuned. So you can just call within 1 hour, you can, okay, CCF, then also we can call. Then the coil is already ready in the OT. So in a same shot, it can be done. That's one advantage. Otherwise, as per the classic description of the book, we can wait. Generally, it was mentioned if it is a direct, definitely treatment. If it is indirect in medium flow, then only you can treat. In low flow, reason is that it may close automatically, especially in case of a trauma in a young patient.
So,
But in a hypertensive, already pre-existing loop is there, so hardly it may be. So in such cases, you can go for a one shot. But in a trauma patient, you can wait. Sometimes the trauma, it may increase also. It is a vice versa. In trauma, it is not in a classic presentation. There may be increase also size. Then we can treat.
thank you, Dr. Jayanta. I think we'll go on to the next talk, which is by Dr. Ashmin. it's an approach to a patient with nystagmus. We didn't want nystagmus to be the last talk. We didn't want to leave you with wriggly eyes and dizziness. So
Thank you, Rohit. Thank you, All India Society, for giving me the opportunity. I'm going to talk about approach to a patient with nystagmus. The most important point is that if you see a patient with nystagmus, would there be any clinical, or are there any clinical signs which you look at to say that this nystagmus would require further workup? So we're not going to talk about management about nystagmus. These are 5 questions that you'll ask yourself if you see a patient with nystagmus. The most important question is that is it present in primary gaze, or it is brought about only when the patient looks to the right, left, up or down? Second, what is the direction of movement? Is it horizontal, vertical, torsional or mixed? Is it jerk or pendular? Jerk is where you have a fast pace, pendular is where the eyes move like a clock. What happens to nystagmus when patient looks to the right, left, up and down, and what happens when the patient converges? This I have converted into my own algorithm. I have not published it, but I think it works. So the first question is A, absent in primary gaze. So there are 2 possibilities. Absent in primary gaze, nystagmus which comes about when the patient is not looking straight can be physiological. That's called end point or gaze ending nystagmus. This is right at the end of the gaze. It is generally transient. So patient looks to the extreme right, there will be some movement which will be transient, which will be low amplitude, and it will settle down. So you don't require to do anything with this. Versus a nystagmus which I'll show here hopefully, where you'll find that the nystagmus is patient looking straight, no nystagmus. Now the patient looks to her left, and there's a nystagmus which is starting before the end of the gaze. So the difference here is that this is starting before even the gaze of the end of the gaze is reached. This is called gaze evoked nystagmus. Now in most instances, gaze evoked nystagmus would require further workup because these patients can be harboring problem in cerebellum. So first, A, absent in primary gaze. 2 possibilities. Is it because of is it physiological, which is gaze ending nystagmus, or is it a gaze evoked nystagmus which will require further workup? These are probable causes. As I said, enough for us to remember that it can be a cerebellar problem. The second feature is this nystagmus vertical? Are the eyes bouncing up and down? This video is not playing, so I'll show you the other one. This was supposed to be a down beating nystagmus where a patient looks straight and nystagmus, the eyes will move like this. So that is a fast phase towards the feet. Now this in all probability is, the commonest cause of a downbeating nystagmus is Arnold-Chiari malformation, where there is a herniation of cerebellum through foramen magnum. There are other causes like drug toxicity or syringomyelia. This is another example of a bouncing up and down, which is an upbeating nystagmus. You see here the fast phase is to the up. So this is an upbeating nystagmus. Vertical nystagmus, the point I want to make here is that any vertical nystagmus would require investigation. So that was a example of an upbeating nystagmus. Generally, again, the lesion would localize to cerebellum or lower brainstem. So that is A, absent in primary gaze. B, bouncing up and down. Bouncing up and down, you have to neuroimage even if patient is asymptomatic, because in all probability it is likely to be a problem with brainstem or cerebellum, except the exception would be in children. Children, especially born with retinal degeneration, can sometimes show a vertical movement. So if you can explain why this child is having a nystagmus, maybe the neuroimaging is not required. C is clock. The eyes moving like a pendulum, and I think I have a video for this as well. And this is an example of a pendular nystagmus where you say that eyes are moving like a clock. Now this was also called, in the past this was called sensory nystagmus. This patient, she's staying in down south in Tamil Nadu, so there is an albinism. So the patient developed this nystagmus because of foveal hyperplasia or optic nerve hyperplasia, which albinism would be associated with. So in most instances, pendular nystagmus is where you look at the fundus very carefully to say, is there any cone dystrophy, congenital toxoplasma scar which causes this kind of pendular nystagmus? Though, if the patient says that this nystagmus was not present, or you cannot explain as to why this patient is having pendular nystagmus, always look at the palate. Pendular nystagmus can be associated with oculopalatal tremor, which can again be a sign of something going on in brainstem. D is direction change, and this is important for postgraduate for you to explain that these patients, so you see this is a left beating nystagmus, this is a horizontal nystagmus. You see it becomes faster when the patient looks to the left. And what happens when the patient looks to the right? So when it reaches the right gaze, the nystagmus settles down. This is called null point. And this is one of the important features of infantile or congenital nystagmus, where patient will exhibit this null point. So that's about D. Infantile nystagmus, these are as described in the textbook, these are the features of congenital or infantile nystagmus. They are asymptomatic, they are mainly jerk, though they can have a pendular or torsional component as well. There is a null zone which is present. When the patient converges, this intensity goes down, and it will increase when the patient is fixating. E is each to its own, and I'll show an example of a seesaw nystagmus. You see here, seesaw nystagmus, one eye goes up and intorts, the other eye goes down and extorts, and this cycle keeps repeating. This is a feature of a chiasmal compression. So, A, B, C, D, E, absent in primary case, bouncing up and down, pendular, look at the palate, direction change, generally this will give you a clue about infantile nystagmus, and unilateral or disjugate nystagmus. To example, one I showed you the seesaw nystagmus, other can be in dorsal midbrain syndrome, patient can have both eyes doing its own thing. Nystagmus by definition is a bilateral problem. I'll end with showing you this particular unfortunate little kid who actually had a unilateral nystagmus. Unilateral nystagmus can rarely be seen in let's say patients who have a dense amblyopia. Unfortunately, I don't have the video there, but so dense amblyopia patient can have just eye which has amblyopia can have a vertical movement. It's called Hyman-Belchowski phenomena. So that kid was diagnosed as having as having Hyman-Belchowski phenomena. But any nystagmus, what we learned from that case is that any nystagmus always make the patient to look right, left, up and down. This patient, when he started looking up, we could demonstrate a seesaw nystagmus. He underwent neuroimaging and he was found to have large craniopharyngioma. But the 6 months were lost because he was treated as a patient with dense amblyopia and was given a patching. So when 6 months later we discovered that it was not Hyman-Belchowski phenomena but a seesaw nystagmus, he underwent a surgery for craniopharyngioma, but unfortunately he did not survive the surgery. So that's the importance of knowing how to make sure that we examine a nystagmus and rule out a serious neurological conditions. Thank you so much.
Thank you, Dr. Ashman. Excellently presented and very nice way to kind of come to a diagnosis. A little surprising that a Hyman-Belchowski was, a seesaw was misdiagnosed as a Hyman-Belchowski.
Because they were only, patient had a poor vision and the nystagmus was observed only in the primary gaze. They never asked the patient to look right and up. So it was funnily, what happened was, when the patient came back after whatever time, so there was a class, and so there was a demonstration which was going on where teachers said that, oh, every patient of nystagmus, you should see, ask the patient to see, look right down, up and down, and when patient looked up, and then he was also surprised saying, oh, there is a
and the patient didn't have any disc pallor?
missed in all probability.
Okay. So it just goes on to show that, we can, even in the best of hands, get surprises, and it's very, very important to do a comprehensive eye exam. I mean, you have to be very, very sensitive or very, very kind of quick to order investigations if any nystagmus is not fitting into a classical I would say there are only three nystagmus. One, he talked about the infantile nystagmus syndrome. One, the fusion maldevelopment syndrome, where you are not going to, you may not, at least fusion maldevelopment, you definitely do not. Infantile nystagmus syndrome, more often than not, you do not require imaging. And the third, which you commonly see, spasmus nutans. In a small child, you must get it imaged because there are reports of chiasmal tumors. But short of that, I think you should be very, very sensitive, or else, of course, you have patients he talked about albinism or children, pendular nystagmus, where you know the reason for subnormal vision. So, congenital cataracts, you see pendular nystagmus for anyone with the retinal pathology. But if you're not able to identify cause for subnormal vision, that itself, and of course in association with nystagmus, is a reason for you to image these cases. So, thank you, Dr. Rashmin. Any questions, or we go on to the next?
Does nystagmus on its own cause subnormal vision without any other problems?
So it works both ways. I'll not say nystagmus will cause a subnormal vision. Nystagmus generally would be a consequence of a subnormal vision. But even those patients with nystagmus in a null point would have a better vision. So you can probably have a surgical approach where you can get the null point to the central gaze.
So there are cases where, like Hertel says, he's done a lot of work. He says that all patients with nystagmus, infantile nystagmus syndrome, should have a null point. It's just that they haven't searched hard enough to get their null point. So if they have a null point, and which is reasonably accessible with moderate head postures, they are able to use that head posture and are able to maintain good vision. However, if they are not able to find their null position, or their null position is in a very eccentric gaze which they cannot maintain, so then their vision deteriorates. So they are not able to, in their early formative years, get a steady eye. So that results in subnormal vision. So yes, we have, earlier that used to be called motor nystagmus, sensory nystagmus and motor nystagmus. Sensory being that poor vision is responsible for the nystagmus, and motor being that more often than not the vision is more or less okay, but that's so.
So they may have a visual disturbance like oscillopsia in acquired nystagmus, but that's not really a vision force.
So thank you. I think we'll now go on to the next talk, which is biomarkers in optic neuritis. Dr. Ambasta Anita, who would be talking, we have made her wait long enough. People in a neurophthal setup, although I know anything behind the lens actually is the realm of the retina specialist.
Absolutely. I'm dealing with these patients as many as retina.
Good morning to everyone. I'm thankful to IOS for this opportunity. I'll be talking on biomarkers in optic neuritis. So optic neuritis, as we know, refers to conditions that involve the inflammation of the optic nerve, but the kind of optic neuritis that we see in our country is different from what we have seen in the Western literature, with many cases having a atypical presentation with a poor prognosis. Now, this is what is atypical optic neuritis, how it will look like. A disc with a lot of disc swelling, absence of pain, and it will be bilateral or recurrent. So just a recap of what is the differential diagnosis of optic neuritis. Apart from the inflammatory, infectious, and idiopathic, we have got these demyelinating lesions like multiple sclerosis, neuromyelitis optica, and MOG IgG associated disorders. It's important to differentiate between these three because they can have similar presentations with optic neuritis or transverse myelitis occurring simultaneously or sequential. But they have very different treatment modalities, and that's why it's important to differentiate between these. So how do we treat these patients and how do we proceed, and does ONTT provide all the answers? If you remember our ONTT, it was basically in a Western population on MS-related optic neuritis, and which gave us the IVMP, as a mode of treating these patients. But it doesn't really provide answers for the atypical cases that we see more often in our part of the world. So just to recap, and many of these atypical cases would be positive for either MOG IgG antibody or aquaporin 4 antibody. So just a representative case to show how it's important for us. Now this was a case which I saw in 2017, way back when we were not doing so many biomarkers, and this was a child ultimately with recurrent optic neuritis. The disc became pale, and we recognized this condition only when the patient got transverse myelitis and long extensive transverse myelitis lesion. So just to recap, this NMO is classically present with severe optic neuritis with poor recovery, which can be bilateral, recurrent, and can also present with severe transverse myelitis. Now, if we just see the treatment, the treatment here, acute attack is IV corticosteroids and plasma exchange for acute attacks. And if we just compare it with what we give for MS, considering that they both can present similarly, we are giving a lot of disease-modifying agents in MS, and these are ineffective for aquaporin for IgG positive neuromyelitis optica spectrum, hence the importance of why we should be doing biomarkers in atypical cases in our practice. Now, this is another patient, which came later when we were wiser, I think in 2020, and this was a young woman with vision less than 6/16 both the eyes. And because it was atypical presentation, we ordered a MRI and we got anterior-optic nerve and sheath involvement, which made us suspicious of MOG, and we got it tested. She tested positive, and we put her on chronic immunosuppression. The vision is good, though the disc has become pale. So these are features of MOG IgG optic neuritis. In most of the cases, they will be bilateral, recurrent. It will be painful. Disc edema will be there in 86% at onset, and 50% will also have enhancement of the sheath, as we can see in the arrow. And again, the treatment will depend upon, treatment depends upon this diagnosis, because that means that apart from the IVMP that we're giving in all these patients, it will be followed by a prednisolone taper over 1 to 3 months, and long immunosuppression. And again, disease-modifying drugs will be ineffective in MOG IgG optic neuritis itself. So advent of biomarkers has marked a paradigm change in how we treat cases of optic neuritis. And just as sum up, aquaporin 4AB in neuromyelitis optica, spectrum disorder, and MOG IgG for MOG-associated disorder, and the typical optic neuritis will be mostly MS-related ones. So do we have any other biomarkers, and are these only used, or are these antibodies only useful for diagnostic purposes, and does MS have anything going for it? So this is what a biomarker is. It is an indicator of normal biological processes, pathogenic processes, or pharmacological responses to therapeutic intervention. It will be present in people with certain disease and absent in healthy people. It will worsen or improve depending upon the disease condition. It will be safe for the patient, easy to detect, and detection method should be highly accurate and reproducible. So these are different types of biomarkers. Some will help in diagnosis, some in prognosis. Some will tell whether a patient whether we can predict whether this patient is going to have a certain kind of outcome, disease-associated activity, and it can also tell about response to treatment, different disease courses. But as in life, there is no such thing as a perfect biomarker. Ideally, one biomarker, for example, MOG or whatever, should be able to do all this. Help in diagnosis, the titer goes up and down, but it's not the case. These are other uses of biomarkers. We can have a role, they have a role in optic neuritis treatment trials. They can help as an inclusion-exclusion criteria for identification of likely treatment responders, and as an outcome measure and so forth. So these are the biomarkers. These biomarkers can be antibody titers, and whether they persist or not, that will also be a marker. And at present, clinically validated and specific autoantibodies in optic neuritis are those which bind to aquaporin 4, MOG, and collapsing response mediator protein 5. This I just saw in a recent article in Lancet. They had added this. Apart from this, the complement protein, cytokines, and other immunological markers, and markers of neuronal and astroglial damage. So if we just come to multiple sclerosis, it would be great, if it had an antibody going for it, because at present it's like a waste basket of diagnosis. Lesions separated in time and space and not explained by any other lesion. So does it have any other biomarker so that we are helped in its treatment? The optical treatment here is determined by individual patient's prognosis and treatment risk, and an integral part of such therapeutic decisions in multiple sclerosis optic neuritis will be the use of molecular biomarkers to predict disability progression, monitor ongoing disease activity, and assess treatment response. And this will also have on the optic neuritis part of the patient. So the important part when a patient comes with typical optic neuritis is, will this convert to MS? Will this convert to a clinical definitive MS? Because if it is, then we'll be starting with some other treatment. At present, we just have MRI and CSF findings when we see patients with typical optic neuritis coming to us to see whether, okay, this patient is going to develop MS later on. So in CIS patients presenting with optic neuritis, not only is the risk of conversion important, but also treatment decisions would be greatly aided by biomarkers that predict future disease activity. Okay, these are certain, there are almost 100 markers in MS, but there are 6 of them which are which are gaining a lot of importance now. And one of them is the serum and CSF levels of neurofilaments, which represents a promising biomarker. So we know about the biomarkers, 2 of them, and this is where we'll be looking into future as ophthalmologists. Again, there is no magical unique biomarker amongst these also for MS. As far as anti-aquaporin 4 is concerned, it's useful basically as for diagnostic purposes, and it's very unpredictable if we see in terms of disease activity, whether we can prognosticate a relapse or tell us about the disease activity. So titers for aquaporin for IgG monitoring would not be very useful, but it's definitely useful in diagnostic purposes. However, for the other purposes in neuromyelitis optica spectrum disorder, we have got different cytokines or markers of neuronal or astroglal damage and complement factors which can help us in telling whether this patient is worsening or whether he's going to get disabled later on or whether he's getting into relapse. And GFAP, that is the glial fibrillary antiprotein, is one important biomarker in MSD, and it's associated with disability and relapses, and it may predict treatment response. So this is something which we can look forward to. And as far as MOG is concerned, the titers of MOG are in fact more useful to us than that of aquaporin, because a patient who, for example, becomes seronegative will be more likely to remain monophasic than have a recurrent attack. And studies have suggested that MOG IgG titers are higher during relapses and may be highest in patients who are presenting with myelitis or ADM. So titers of MOG may be more useful for us than aquaporin, for example. And these are CRMP5 antibodies which are expressed by oligodendrocytes, and these can be raised in patients who are having paraneoplastic syndrome, especially small cell carcinomas with dyskidemas. This might be raised in these patients. So this is just a summary of biomarkers in optic neuritis. The etiology of optic neuritis varies widely and calls out for different treatment options. Knowledge of old and new biomarker puts us in a better position to evaluate various etiologies and provide better outcomes in even recalcitrant optic neuritis entities. Thank you.
Very nicely summed up, though I know quite a few of these probably may not be available for a general use.
Yeah, exactly, yeah.
So, but I mean, it's good to know, because that's where probably we'll be going 1 or 2 years.
Yeah, exactly.
From now.
That is what my thought was, that just as we didn't know about the aquaporins initially, probably we might be just proceeding towards there, and it might be of some use to us.
When you said, doctor, that disease-modifying agents would not work, what are disease-modifying agents?
Yeah, we have got a lot of trials, Evanex, and these are interferons which we're using here, which are not going to be working there.
So actually, like you have a lot of now treatment of MS is fairly well established now. I mean, the treatment would be first you'll give IVMP, followed by, depending upon the risk of development of multiple sclerosis based on the profile of the patient and the MRI, think in terms of discussing essentially antiferons, although there are interferons, although there are other alternatives which are lower cost. Again, these have to be given in association with the neurologist, because you at least need to give them for at least 2 years or more, and they are fairly expensive. They not only are not seen to work in NMO, but they are actually now considered to worsen outcomes in NMO, in which case, because you have clear circulating antibodies, we are, instead of disease modifying, we are giving immunosuppressives. So if you suspect, or if the patient has NMO antibody positive or even MOG, then if the patient doesn't improve, particularly in NMO that we see, we think in terms of immunosuppression as the next, as azathioprine. In fact, one of the most frequently used, and in those
this is one of the most frequently ones which we also use.
So again, unfortunately, there are no clear endpoints to this. So one, we start steroids and transfer to oral steroids, and the oral steroids itself continue for a long period of time. So no more is the ONTT trial 11 days and also you give 3 months or more, and subsequently you shift them, so treatment continues to up to 2 years or more, depending upon how the patient moves and relapses. So
Generally a mild MOG with a mild clinical feature, 1 year or so is what neurologists would give. Though there is a controversy, a lot of people say MOG may not require NMO might be much longer, because there were always a chance of recurrence and chance of the spine getting involved and patient getting paralyzed. In fact, the threshold for even plasma exchange is
It's very low. Yeah.
if the patient doesn't improve on IV methylprednisolone and is NMO positive, if the patient is you do a plasma exchange. Even patients as late as 2 weeks have shown to improve if you do Plex in these patients. So thank you. We'll go on to the last talk of the day, which is role of neuroimaging in ophthalmology from general ophthalmologist point of view, Dr. Jayanti Kashyap.
Dear regards to all the stalwarts of neuro-ophthalmology present here, and a very warm good afternoon to all of you. So I am here to present on neuroimaging in ophthalmology from a general ophthalmologist point of view. So as said by father of neuro-ophthalmology, neuroimaging is that subspecialty of ophthalmology where diagnosis is made upon the reinterpretation of alleged normal scans, and hence the importance of neuroimaging. So the question arises, why to order, what to order, and when to order? Well, as we all know, neuro-ophthalmology is a little bit complex topic, but it has been revolutionized by the current imaging modalities, and the diagnostic yield is optimal when the ophthalmologist and the radiologist collaborate in the radiodiagnostic workup. And we all know that the person who does these scans, namely CT, MRI, he is a technician, he is not a doctor. So unless we specify what we are suspecting, where we are suspecting, and many times patients, especially in periphery, in government setups, they may not ready to go to a neuro-ophthalmologist, it may not be available in the city. So our aim should be to make a diagnosis and then to refer so that we can explain to the patient the seriousness of the case, or whether he or she can wait. So what are the problems faced by a general ophthalmologist sitting in a busy OPD, especially in periphery, in government setups, and also in private practice with lot of bread and butter cases to dispose of? We often tend to keep these special cases at the end, and we often get confused what to write CT, MRI, what exactly to write CT brain or CT orbit with contrast, without contrast. Then we have the tendency to refer at the higher center without arriving at a proper diagnosis, and we also have a tendency to straight away look at the report instead of the film. So what are the errors in neuroimaging? These are the prescriptive and interpretive errors. Errors on our part could be failure to order request for a correct study, omission of contrast or specialized sequence, and interpretive errors like misleading clinical information and low sensitivity of imaging. So I will quickly discuss the common imaging modalities, pitfalls, and the common clinical conditions. These are the gamut of imaging techniques which are available nowadays with CT, MRI, lead array of detectors instead of a single X-ray plate. And this we get based on the attenuation caused by different tissues. We get an image like this, and so it is basically a densitometer, and based on the density of different tissues we get the images, and where water and air, they have negative densities and they appear black, water appears neutral, and bone appears white on CT scan. So disadvantages, as we all know, radiation, contrast allergy, and osseous artifacts, but the advantages of CT are less time, less expensive, and it is indicated in all cases where MRI are contraindicated. Indications I'll discuss one by one. So what are the things to keep in mind before ordering a CT scan as a general ophthalmologist? Slice thickness is the most important, because unless we mention the slice thickness, the normal slice thickness for CT scan abdomen or any other part is 10 mm. And for ophthalm, you have to remember that for routine we have to mention 2 mm cuts, and if we are suspecting something of the optic nerve, we have to mention 1 mm cut. Because if there is a tumor of say 5 or 6 mm, and if we don't specify, and if the technician is not that well expert, we may easily miss. So we have to order CT brain orbit with thin 2 mm cuts, exactly we have to specify. Then regarding contrast, in cases where we are suspecting vascularity, to know the surgical approach and whether how much it is enhancing anything which will give a contrast. If it is vascular, it will enhance. So there comes the role of contrast. Then imaging planes in CT, normally we get only axial images, and the coronal and sagittal, they are reconstructed. So this is the Reed's line, which is the orbitomeatal line passing from the inferior orbital rim to external auditory canal. Any line parallel to this is the axial, and any line 70 degree to approximately 70 degrees is the coronal, because if it is 90, it will the teeth will get the artifacts. So tissue window is one thing which we should important. There are two tissue windows, soft tissue window and bony window. Like in this image, we can see that the bone, the lens, and these soft tissues, they all appear to be of the same density. And here it looks like there is a medial wall defect, so we cannot clearly say. So we have to order a bony window in which the bony details will be clear, and we can see that all the bones are intact. So, and we have to also keep in mind that like special techniques like in patient with orbital varices, if we don't specify like we have to perform CT with while doing Valsalva, it may be missed because in supine position it will not be visible. So normally we don't get a single scan, we get a series of scans like this, and the images are from caudocranially, that is from bottom to top. And in, if we use this lens and the optic nerve as the landmark for mid-axial scans, we have to see few images above and few images below it. Like, and this, whenever you are ordering CT orbit, please mention the cut size, as I said, 2 millimeter cuts, because in this, they have given 5 millimeter cuts and you can see very few images of the orbit. So mention the cuts, and these are the coronal scans which we get. So I will quickly rush to the indications. In cases, any cases with, in which bone is involved, you have to order a CT scan. Like in optic canal fracture, here you can see in the right side there is the avulsed and retracted optic nerve. Any cases of orbital floor fractures, RTA, these are very common presenting in any government setup or in periphery. So just to remember, you have to always ask for the coronal reconstruction in suspected orbital fractures, because in normally they carry the axial images with the patient party, and if we look for fractures, we will easily miss. So always ask for coronal reconstruction. And as I mentioned, order for CT brain and orbit non-contrast, because in fractures you don't need contrast, thin 1 to 5 millimeter cut. These are special techniques, volume reconstruction techniques, in which you can easily see the cut and plan the surgical management, whether it can be managed conservatively in the periphery, because many times patients are not ready to go outside. Whenever a patient presenting with bilateral proptosis coming to the OPD, order a CT scan, and like in this case, most common is the thyroid eye disease, and the CT scan findings include enlargement of the muscles with sparing of the bellies. And in this, the coronal image you can see for comparison of the both the eyes. And so it's also, in this also you have to ask for the coronal images for the comparison. Just a word about thyroid pseudotumor. In comparison to thyroid disease, in pseudotumor, the whole of the muscle along with the belly is enlarged. So also in orbital infection, especially in children, to differentiate between preseptal and septal, in this you can see in the left side, the opacification is situated just anterior to the septum, and the periorbital fat is clean here. So it is just preseptal. And in septal, there is opacification of the periorbital along with this proptosis. So this, in any foreign body, you have to first order a CT scan, because as we all know, MRI is contraindicated in metallic foreign bodies, and many a times the nature cannot be uncertain. So quickly I will rush to MRI. It is just based on the principle of excitation of hydrogen ion, and as we all know, our body is made of 70% water, which contains hydrogen ion. So when we give a brief magnetic pulses, these excite, the ions get excited, and it comes back to its original state, and this sequence is captured, and there are two basic sequences, T1 and T2. Important thing to remember is T1 is good for anatomy and T2 for pathology. And how to distinguish? Just remember that water or any fluid is dark in T1, and so in vitreous and the adjoining CFS, it is dark in T2. So these are the modifications. Just a word about FLAIR, because whenever a lot have been discussed about optic neuritis, whenever you are suspecting optic neuritis, if you don't have so much, you just order MRI brain orbit along with the MS protocol, multiple sclerosis protocol. And just a word about FLAIR, as I said, in T2 the CSF is bright, but in optic neuritis we have to search for the demyelinating plaques. So the intensity cannot be, so in FLAIR what they do, the CSF signal is suppressed, so we can find out the, this the diffusion mating I will skip. So just in optic neuritis, as I said, this is the case of optic neuritis, and this is the enhancing optic nerve. So order for contrast brain and orbit with fat suppression and along with FAIR sequences. And also such patients coming to the OPD, 45-year-old presenting with diminished vision, and on like we can see the pallor and along with collaterals, order an MRI, because in cases where you are suspecting optic nerve, order an MRI, do the diagnosis and then refer the patient. In this case we can see in contrast MRI brain and orbit the typical tram track appearance, the optic nerve traversing through this. And so just a word about differentiation from optic nerve glioma, in that you can just see the enlargement and you cannot see the track of the optic nerve. So in cases presenting with any cases in which we have fields respecting the vertical meridian, do order an MRI, particularly sellar region, mention the sellar region. and then you will get this typical snowman or 8 or the figure of 8, and also in patients presenting with complete ptosis and pupillary involvement, do order a CT scan brain and with contrast, and you can see this aneurysm of the right posterior communicating artery and CT angiography. Just to, even if it is not available, you can direct the patient to refer. So the take-home message is to do look for the film along with the reports and try to work up the cases before referring to neuro-ophthalmologist, correlate clinically and do properly communicate with the radiologist. So after all that shades of black and white, colorful, thank you.
Thank you. Thank you so much. It was very nicely covered. Any questions for her? Any comments? One of the sure signs that neuro-ophthalmology is becoming quite popular is that we have a leading cataract and refractive surgeon of India sitting here in a neuro-opthal session and attending it.
Including the retinas, and now we have a cataract refractive also. So we are.
Thank you, sir.